Hi everybody. Hope everyone is okay. Um, Hopefully we'll have another interesting ECG today. My apologies if there is a bit of background noise. My children are on holiday, and well, I mean, everybody's children are on holiday. Mine's working on one another's nerves, so there's a bit of shouting in the background. So my apologies for that. If you do hear, I'm sure you can already hear it there in the background. But so for those of you who are on the group, the A&E group. You would have seen the ECG that was posted yesterday. I think I did post it yesterday. And as usual, for those of you who are joining live and for those of you who are going to watch this later on YouTube, if you do have any questions while we're busy or later on after we're done, and if you're watching it later, you're more than welcome to ask me on the group or or you can ask me directly now on the chat. And like I say, thank you for those of you who join me live. There's a few of you who always join me, and I really do appreciate it, and I hope you really do learn something from it. So let's get into it. And like I say, if there's any background noise, you really do have I really do sincerely apologize. So what we have here, now I'm so sorry, the bottom of it just got cut out a bit, and that might have helped some people, is that we have a young man who actually presented with intermittent palpitations. Now, this is an interesting ECG because at the time of the ECG being read here, you'll notice that the patient is not in a tachycardia. So, if you notice, it's less than 100 beats per minute and it seems to be okay. So that means that the patient has something that's triggering off palpitation. But the question is, what is it? And if you look at the ECG, you notice immediately some, strange phenomenon. But let's go through it step by step and let's have a look at it and see. So the first thing we do is sorry, let me get this up properly. I just want to get the laser pointer so that it's a bit better for everybody. So here we have lead 1 and lead AVF, and we notice that lead 1 is mainly positive and lead AVF is mainly negative. So this means we have a left-sided axis. So the electricity is being pulled towards the right. So this patient may well have left ventricular hypertrophy, or may also be experiencing damage to the right side of the ventricle, I mean, to the right ventricle or right side of the heart, and that may be what's leading to the left-sided axis. However, if you look at this one, it's more likely to be left ventricular hypertrophy. The reason for that is deep waves in lead 3 and the tall waves in lead AVL. Okay. So let's go into the rhythm itself. So the first thing we note is that we have our P waves. So the P waves themselves look relatively normal. Okay, so there's not much of an issue over there. Now, this is an interesting one because what we've got here. Now, most people would go, this is your R wave, and that's 1, 2, 3, 4, so that's within normal. But actually, if you look at this, what we're seeing here is we're seeing a P wave, there's an R wave, there's an S wave, there's an R prime, and there's an S prime going down again. So it's like an RS type of pattern that we are seeing over there. And here, if you compare it, for example, that's on lead 2. If you look at some of the other leads as well, you notice that getting into our R, from our P to our R is actually not that long. We're getting just to about 2.5 to 3.5, blocks, tiny blocks. And in fact, if we come here where we've got little R waves and maybe a little S wave over there, we notice that our PR interval is quite short. In fact, if we take this as our R wave, we actually see that we've only got maybe about 2 to 2.5. So we've got a very short PR interval. That's the first thing, all right? So shortened PR interval means that the time between the atria and the ventricle contracting is quite short. Now, there's a few reasons for that to happen. Number one, you may have, for example, accessory pathways, which is the most common. The second one is pre-excitation syndrome. Now, pre-excitation syndromes, what that means is that you have, for example, your heart. Let's try and draw it out a little bit just so that people may understand what we're getting at. So I'm going to try and draw it to the best best of my ability, but I may not be that good. So let's have a look. Let's say we've got our SA node over there, we've got our AV node over there, and then we've got our what you call it, our branches and our bundles and things like that, and everything is coming out. And let's make another line just over here, just to show where our atria and our ventricles separate. Okay, so let's see what's a good color for electricity. Let's put electricity as blue. So normally what happens is that you have your electricity moving from your SA node to your AV node. Now, what happens in some of these pre-excitation syndromes is that you have extra little pacemaker cells over there or accessory pathways or whatever it may be. And what happens is when your heart gets excited, or in other words, when the SA node stimulates the AV node, these also get excited. And when they get excited, they basically send electricity back this way. Okay, now that's the simple way to understand it. So what happens is it's pre-exciting the ventricle. So it reduces the amount of time between what we see as an atrial contraction and a ventricular contraction. Now, if you really want to become a cardiologist, you'll eventually learn about electricity that goes this way. All right. So it's prodromic and orthodromic syndrome. Now, I don't want to get into that because everybody will just switch off and immediately rather go and watch something on TV. So I'm not going to get into that too much. But the easiest way to remember it is that SA node sends to the AV node and then also at the same time excites these, these accessory cells. And these cells now produce an accessory pathway for electricity to go through to the AV node again. So you're having this circular, well, not necessarily circular, but for the sake of this, let's say it's circular. It just keeps on going round and round and round and keeps on exciting the ventricle. Now, what that does mean is that there's a very high chance that a patient will end up having palpitations at some point. In other words, a patient will go into a tachycardia at some point because as that goes around and around and around and around, it just eventually excites it. So that's one of the things that we find. Now, our QRS complexes are narrow, even though most of them are quite normal. In some of them, we can note, for example, we see an RS wave and things like that. But one of the things that we note is that there seems to be, and I think it's most pronounced here on V6 and V5, is that we have this, let's draw it out over here. Let's get a straight line. We have what seems to be like a little slur. Okay. So let's just draw it out. Sorry, maybe we can make that a bit thinner. Let me just try that out. Not sure if I can get it thinner. Yes, we can. And let's make it in a bit of a better color. So what we notice is that in this QRS complex, there seems to be this uptick, and then it sort of does just this, it sort of slurs away and then goes into the rest of the complex. And it's most pronounced over here. Now, this was what I was hoping people would actually take note of because that's a very special type of wave. Here you can see it to a less pronounced extent, but you can see that there's definitely a prolongation that's taking place. All right. And in each of them, it's taking place to a slightly different extent, but it's definitely taking place. Here in AVR, you can actually see the upside down version of that, where it just seems to slur away. It starts and then it takes a little bit longer to get where it's going, So we have some oddities that are going on in our QRS complexes as well. However, they do remain narrow. In some areas, they do look a bit wide. Here you can see it's actually quite pronounced in V2 and V3. That slur, sorry, I missed that actually. But that slur is quite pronounced. And besides that, our QRS complexes do follow every single P. So the ventricle is contracting after the atrium. And we notice that they are quite regular actually. So what we have here is a patient who's having occasional palpitations, who's having occasional tachycardia, who has what appears to be a shortened PR interval. In other words, there's less time between the atrial excitement and the ventricle contracting as well. Now, this is an important one to know in our emergency departments. And the reason why I had chosen to actually discuss this is a very particular syndrome that we're talking about. And if you're lucky enough to work in the emergency departments for quite some time, you'll actually see this from time to time. Now, the reason why it's so important, But okay, let's say even before we get into that, the one thing I can tell you is there's no, as far as I could see, there were no real signs of ischemia, although there were some ST depressions in a couple of these. So you could even argue that there may be some ischemia. Could there be an ST elevation over here? It's possible. So could there be an infarct going on? Definitely, there's a possibility. So these are the types of things that you would look at. I'm so sorry, I got so hung up on the example. I forgot to look using my own method as well. So apologies for that. So we've got a patient who has occasional palpitations, who has a very narrow PR interval, and who has an abnormal slur in the QRS complex, and we also have ischemia as well. All right. Now, if you were the type of person to work in an emergency department and send this patient home, then you would be at fault because there's quite a bit that's wrong over here. So what would you do? You would do enzymes, you would do your baseline bloods, and at least you would probably try and do a rhythm strip, a longer rhythm strip. Maybe, as I mentioned before, put your machine on manual and let it run for a few minutes and see how it goes, and if you maybe pick up the tachycardia and the possible palpitations as well. Now, you may or you may not, but at least you're going to give yourself that possibility. And let's say you're working in the emergency department. If you make the diagnosis, that's great. If you don't and you realize there's something wrong and you ask somebody for help, or you pass this on to, for example, the medical or cardiology department, even without a definitive diagnosis, but having discussed with maybe the reg or the medical officer, you will actually have a huge impact on this patient's life. So let's have a look at why. So this is actually Wolff-Parkinson's-White syndrome, and it is the most common ventricular pre-excitation syndrome. All right. So what are the common things that we see? We see a shortened PR interval, which we have, a prolongation of the QRS complex, which we have. It's not a wide QRS complex, but it is a prolonged QRS complex. And the slurring upstroke, which we had seen over there, which is called a delta wave. Now, if you can remember this delta wave and the PR interval being shortened, you'll diagnose Wolff-Parkinson's-White the majority of the time. Now, the question is, why is it important to recognize this? The reason being, very often these patients are symptomatic, and by the time they come to the hospital, they're asymptomatic. Then they become symptomatic again, and they're asymptomatic by the time they come to the hospital. They very rarely have sustained tachycardias for extremely long periods of time. And even if they do go into ventricular tachycardia, it's not the most common presentation. So you have sort of like a vicious cycle of patients presenting with palpitations. Somebody sees them once, doesn't recognize it, sends them home. The second time they come, another doctor looks at this and says, oh my word, this person has been here before. They did everything. They found everything to be normal, and the patient is just complaining of the same thing, may send them home again, not recognizing the abnormalities. And the more that happens, the more you get bias against the patient, because more and more doctors will now look at this and think, okay, this may be panic attack, this may be a hypochondriac, this may be a patient who doesn't really have a physical problem. However, if you pick this up, you'll really you'll change this person's life because they respond very well to therapy. So these are the cardinal signs and symptoms of Wolff-Parkinson's-White syndrome. And like I say, it is the most common ventricular pre-excitation syndrome. And as I had mentioned, the reason for that is that you have this accessory pathway. Now, the exact name of it is called the bundle of Kent. So if you can remember that, that's very good. I've been teaching the subject for many years. I always remember it's called the bundle of something. And the closest I can remember is a bundle of something to do with Superman, because Superman's alter ego is Clark Kent, but I never remember Kent. So I'm just letting. So what happens is it actually bypasses the AV node and it leads to early ventricular excitation. So the actual pathophysiology behind Wolff-Parkinson's-White itself is quite interesting if you have a chance to go into it. But the main thing to remember is that it is a pre-excitation syndrome. It's not it's not uncommon. It's 1 to 3 per 1,000 people. So if in an emergency department we are seeing 3,000 people, let's say per month, there's a chance you maybe see between 3 to 9 of these a month. Now we don't. You normally see about 3 to 4 a year, but there's still a good possibility that you will see quite a few if you work in an emergency department for quite some time. What are the signs and symptoms? So palpitations are the most common. They are sudden onset, usually associated with tachycardia, but they also are they resolve quite abruptly as well. That's the thing. So that's why I say you have this patient who comes in, goes, but not necessarily with a sustained tachycardia. Dizziness and syncope can happen if the tachycardia is extreme, and is of course, we've learned about tachycardia as one of the cardinal symptoms, of course, is hypotension and decreased cardiac output. Chest pain is more common in older patients because of decreased coronary artery return during the diastolic phase. Fatigue during prolonged periods of tachycardia, which aren't that common. Sudden cardiac arrest, not common, but it can happen if the patient suddenly goes into a ventricular fibrillation, which can happen if the patient has had this for an extremely long time. Okay, so what do we do for in the emergency department? So if we have a stable patient now, generally, if you have a stable patient with tachycardia, this is what we are talking about, tachycardia. So your patient comes in, you even diagnose the Wolff-Parkinson-White, but the patient is currently tachycardic but stable. Then you would try, for example, carotid sinus massage is there, Valsalva maneuvers are there, your revert maneuver is there. You can try any of these maneuvers to try and bring it back down to normal. And then our next step in terms of medical treatment would be amiodarone, which we've mentioned many times before. Procainamide is normally used overseas, UK, Canada, places like that. But in SA, we would use amiodarone. So you'd normally put you would probably give the patient a loading dose of about 150 milligrams in about 200 mils. It normally goes in dextrose, I think, and in Ringer's lactate, if I'm mistaken, not normal saline. And you give that over about 10 minutes, and it normally slows the heart rate down. One of the things to avoid is anything that may block the AV node. So we don't give adenosine, we don't give beta blockers, calcium channel blockers, or digoxin. Okay, so there is a risk that you may increase the rapid conduction through the accessory pathway. So that circular thing that I was explaining to you earlier can become a lot faster because now you're bypassing that AV node again. You're basically blocking the AV node, so you're allowing the accessory pathway to actually excite the ventricle much faster than what you would normally do. Now, sorry about that. Okay. I hope this makes sense so far. The important thing is that most of you should be able to recognize a tachycardia by now. The question is that do you recognize the diagnosis behind it, which is Wolff-Parkinson's-White? And if you've never recognized Wolff-Parkinson's-White, I hope you will remember it now because it really is very easy. That delta wave is not common in any other situation. So I hope you will remember that. Now, unstable patients we treat as though we would normally do for any unstable tachycardia. You would cardiovert them, as we've mentioned many times in the past. Now, and then, of course, you would probably admit them to your ICU or cardiac high care, and then they'd be managed from there. So the most important thing is that once the diagnosis is made, and if it's made from the emergency department, it's even better because really, it makes your emergency department look as though you know what you're doing. People are looking at the ECGs, they're studying the ECGs, and it's not that we just leave everything up to the physicians and the cardiologists, but these patients eventually do have to go to electrophysiologists in order to receive ablation. And they do very well with ablation therapy because once you remove these accessory pathways, there's nothing to excite that ventricle. And once there's nothing to excite the ventricle, there's no Wolff-Parkinson's-White syndrome anymore. Now, if the patient does not receive ablation, which there may be contraindications too, then they just require lifelong checkups with their cardiologist. The complications of Wolff-Parkinson's-White are sudden cardiac arrest, like we said, but this would normally be a patient who's been in tachycardia for quite some time. I was trying to look through the literature. I couldn't find many instances or many cases of cardiac arrest on patients with known Wolff-Parkinson's-White, but it is there, but it doesn't seem to be very common. And eventually, patients can progress to atrial fibrillation with rapid conduction. This has been noted a bit more, but more especially in older patients. So just something to remember over there. So the biggest takeaways from all of this is that you need to recognize the triad for diagnosis, which is the short PR interval, the delta wave, and the wide QRS. So let's just go back and look at it again, just so that we can see. So the shortened PR interval, the prolonged QRS complex, and the delta wave. Now, this was one of the best examples of a delta wave we've ever seen. And that's why it was in this particular textbook, and that's why they showed it. And it's a nice, lovely thing to see. So, like I know myself personally, I've only diagnosed it twice, or I found two patients with it. So it's not as though it's not as though you'll be seeing it every day, but it's lovely when you do pick it up. Remember to avoid beta blockers, calcium channel blockers, adenosine especially, because if you follow your ACLS protocols, one of your treatments, of course, is adenosine to try and stop your tachycardia. So it's not advisable in this particular case. And of course, the most important thing is to stabilize and send the patient for ablation. This is just a little joke to finish off. So tachycardias, we've covered many times. And I just felt this was an important diagnosis to make. There are other types of pre-excitation syndromes that you do see, such as LGL, Leukonon-Levine, Wolff-Parkinson-White is there. You get prodromic, orthodromic. There's so many things. And if you are somebody who gets into, internal medicine, cardiology, and goes further down that field, of course, you'll really have to know that quite well. But for those of us who are working in the emergency department, even if can get to the diagnosis of WPW, you've done very, very well. So, I hope you guys will be able to recognize those three things: the short PR interval, the prolonged QRSs, and the delta wave. With the delta wave being probably the most common or the most easily recognizable. People may still debate about PR intervals, but the delta wave, once it's there, it's almost pathognomic of Wolff-Parkinson's-White syndrome. I'm not sure if there's any questions or if anybody would like to know anything or if everybody's happy. You can ask me now on the chat as well. I'll just bring that up. So if there is anybody who wants to just ask anything, that's great. But if not, then, we'll kind of call it there today, and we'll try and have another meeting, another teaching session on Wednesday, and we'll discuss another topic. And again, thank you to everybody who joined. Thank you so much. I really appreciate it, Leanne. And thank you to you. I know you always join us, and I'm really thankful to you for always participating. But yeah, that's going to be the end of it for now. And we're just going to stop the recording. And so I hope that all of you enjoyed it and that we'll have another one soon. Thank you very much. Keep well and bye.